Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Cancer Conference Update. As today we go back and talk about the ESMO Congress in 2025, just a few months ago. We're going to talk about what was presented there in gynecologic cancers. Dr. Ritu Salani, from the David Geffen School of Medicine in UCLA in Los Angeles, is our faculty person for today. We're going to talk about ESMO and GYN cancers, and ESMO was a pretty active meeting in general. A lot of great papers in many different tumor types at ESMO, including gynecologic cancer. So I'm really looking forward to doing that, and also kind of getting an update from Dr. Salani about where we are right now in general, the management of ovarian, endometrial, and cervical cancer. As in all of our programs, we will at times be talking about the use of non-FDA approved agents and regimens, so check out the prescribing information for more. Here's where we're heading. We're going to be doing cases from Dr. Salani's practice for each one of these modules. We'll start out talking about ovarian cancer, then endometrial, and then cervical cancer. So, Ritu, we're going to start out with ovarian cancer. I also want to use this as a time to sort of touch base with you about where we are in general with upfront management, and then we'll talk about platinum resistance. But kind of as a way to kind of get into the topic, can you tell us a little bit about this 39-year-old patient, pretty young for ovarian cancer, what happened to her?
Yeah, so this is a very young lady who presented to me. She had imaging that you can see here, and I'll kind of just summarize it, but it showed pelvic masses, but also extensive abdominal disease. When I first met her, I actually thought this was a low-grade serous cancer. And so even though we had this extensive disease burden, I took her to the operating room for a diagnostic laparoscopy. We saw carcinomatosis, we saw disease, but we did actually feel like it was resectable. And so we performed a large converted her to open and performed a debulking surgery, which you can see required a splenectomy and additional procedures. And she was her final diagnosis was confirmed as high-grade serous ovarian cancer, and her final stage was a stage 3C. So in kind of with current practice, we gave her carboplatin and paclitaxel. I added bevacizumab with cycle 2 after she had her surgical healing, which she completed 6 cycles of in June of 2024. During this time, we also got tumor testing. I didn't put it down here, but she also had negative genetic testing or germline testing. But her tumor testing showed that she was p53 mutated and HRD positive. So she had a post-treatment scan, and then she received bevacizumab and olaparib maintenance, and kind of in lieu of consistent with PAOLA-1 data. And you can see her CT scans as follow-up show that she had an excellent response to therapy, some kind of post-operative scarring maybe. She completed her bevacizumab, and she's completing her, she's on her olaparib right now, which she'll complete after 2 years. Here's just an overview of her CA-125, which you can see was never really highly elevated. Made me also think low-grade serous cancers initially, but she's had a really lovely response, and which continues to today.
So before we take a look at what happened at ESMO with regard to upfront management, can you kind of summarize the way you approach, first of all, patients who are BRCA positive, whether it's somatic or genetic, patients like this one who are HRD positive, and BRCA wild type now in terms of PARP, BEV, et cetera? What's your usual strategy?
Yeah, so I do want to highlight that both tumor testing and genetic testing or germline testing are really critical parts of patients' care with high-grade ovarian cancer. And in patients who are BRCA mutated, I will always favor a PARP inhibitor in these patients. And I am speaking to more advanced disease, although I think there is some data leaning towards stage 2 patients as well. But a PARP inhibitor really is standard of care for those patients if they can safely tolerate it. In the patients who are BRCA wild type. So I'll skip the HRD population for a moment, but those patients I think continue to represent a challenge. We do have bevacizumab maintenance, which is kind of a approved option for these patients. And there is a kind of a rush of studies that are kind of hoping to fill that space because we really haven't seen anything really effective in those areas. We did have PARP inhibitors with initial approval, but that did get withdrawn after we didn't see it convert to an overall survival benefit. The HRD population, I maybe have a little bit of varying practice. So some patients will receive PARP inhibitor. I think PARP inhibitor should definitely be part of their strategy if they can safely tolerate it. Sometimes I add bevacizumab. Sometimes I'll use PARP inhibitor therapy alone. And that's just mostly based on patient profile, patient toxicity tolerance. You know, I live in Los Angeles and sometimes patients can't travel, but I usually generally favor a PARP inhibitor and bevacizumab in those patients.
And choice of PARP inhibitor?
So, with bevacizumab, because of some of the toxicity of hypertension, I'll usually favor olaparib, and that's what PALA-1 is. There is some data looking at niraparib and bevacizumab. It's earlier phase 2 single arm data. So I think you have your choices, but the only FDA approval is with olaparib, and that's what I'll use with bevacizumab.
What about when you're using PARP alone in a BRCA patient?
So it depends. I give the patients the option. Some patients like once a day dosing versus twice a day dosing, tolerance and side effects, hypertension and hematologic toxicities really do matter for these patients. So I think there's a little bit of strategy. There's a little less drug-drug interaction with niraparib versus olaparib, so that sometimes also factors in. So it's really a personalized decision for those patients. And honestly, I use both depending on different situations.
And any 2026 update in terms of risk of AML and MDS in this situation? What do you say to your patients?
In the frontline setting, we actually see really low rates of myeloid neoplasia. So I think it's really safe to use PARP inhibitors. Unfortunately, you will see some. That's pretty rare, about 1% of patients that you'll see. And I think this is a really important thing to stop the PARP inhibitors based on, we typically use 2 to 3 years, depending on which PARP inhibitor you're using. I think we've shown that you can safely stop it. And I think that's important to help avoid unnecessary risk of myeloid neoplasms.
So, interesting case that I'm actually not going to present to you because it looks too complicated from Uzoma, but I just want to bring up the fact that she looked at ctDNA in the patient. I'm just kind of wondering, as of course, we're hearing a lot about, we just got back from the ASCO GI meeting. We're talking a lot about ctDNA, obviously. But are you or anybody else using ctDNA in upfront management of ovarian cancer?
I'm trying to figure out how to incorporate it. I think that, I'm a big person on survival kind of impact. How does it influence my behavior? What's the meaning of it? And, there are some data that show that maybe ctDNA starts to rise a little bit earlier than CA-125, so it may be more sensitive of a marker. But I haven't seen that translate to survival data. And so what do I do with an elevated ctDNA result? Do I start treating the patient even if there's absence of disease? I do think as we get more effective treatments, this may become something that's thought about, but I think right now I'm still a little unsure of how to incorporate it. I have that discussion with my patients. A lot of patients are bringing it up now, so I think it's an important thing to acknowledge. I just always tell them it's maybe not interpretable just yet, or we don't know what to do with that information just yet. I think the biggest thing it does for me is help me. Maybe I'll surveil a patient a little bit more vigilantly than I would if their ctDNA was negative or low, stable.
So Colton in the chat room wants to know what you do in terms of stage 2 high-grade ovarian.
So it's a great question, and I think it depends. If they are a BRCA mutated patient, I will generally, if you're asking about maintenance, I will generally favor a PARP maintenance strategy for them. If they are not, then I usually just, do the 6 cycles of chemotherapy. I don't typically use bevacizumab for those patients with stage 2 or stage 1 disease in frontline, so those patients just go into surveillance protocols.
Yeah, that was actually his question. All right, let's talk about some of the papers from ESMO in the upfront setting. For these first two, I think are kind of interesting. One, kind of I guess I could say the age-old question of dose dense paclitaxel carbo. Another attempt, kind of convoluted story there, but what's the bottom line? And it seems like this maybe is not going to necessarily move the needle, so to speak, or is it?
I think you hit the nail on the head. I think this study it's interesting. And I think we've gone back and forth about weekly versus conventional 3-week dosing. And I think one of the issues with this study is that, the role of PARP inhibitors, testing for molecular markers really what didn't inform this study. And so I think there may be a benefit, but I think we know a little bit more. So I think the study kind of got outpaced by science. And so that's why I think it won't move the needle. I don't think it's inappropriate or a bad option to do in patients who choose to do it. But I think it's probably not going to change practice too much.
So interesting paper there. I'm going to call it Fuso, another PARP inhibitor, but now with TKI, apatinib. Can you talk a little bit about this trial that came out of China?
Yeah, I think this trial is interesting, and I think it kind of maybe fills a gap of where PAOLA-1 didn't. So one of the big concerns with PAOLA-1 was olaparib bev versus bevacizumab alone. And this one actually looked at Fuso, or Fuzu, however you want to say it, with apatinib versus Fuzu alone. So you actually had a little bit of that kind of PARP alone. So I think that was kind of an interesting thing to see. And I think it kind of showed us that maybe bevacizumab or patented in this case, may not really add much to those patients who have HRD or BRCA mutations. And so, different drugs, different settings. So I think it's, all has to be taken in context. But I think it kind of complements what we know about the role of PARP inhibitors in these patients. But I think it also maybe puts into question that missing arm of PALA-1.
So another paper I want to ask you about here, does the addition of dostarlimab, the whole question of can IO be incorporated into the upfront maintenance? It seems like there are a bunch of trials looking at that. Seems like nothing has really changed what we do. This was looking at how dostarlimab affects niraparib toxicity. But also we saw more data from the duo. I was telling you before we got started, these duos, the combination studies are so complicated. It's kind of hard to figure out what they mean. But the bottom line to me was looking at the issue, again, of IO in the upfront setting and the maintenance setting. And we also saw, again, at ESMO, saw data from the Pembro study with looking at chemotherapy. Can you kind of summarize the bottom line of sort of where we landed in terms of the whole issue of IO? We're going to get into platinum-resistant disease in a second, but what about upfront with these various studies?
I think the role of immunotherapy in the frontline setting really just hasn't panned out. So I think we see these kind of maybe small signals. You can identify these subgroups, but I don't think we've shown a proven role for checkpoint inhibitor therapy in frontline ovarian cancer. So I think, we maybe need to find some different groups. Now, that excludes the DMMR population who may have, for ovarian cancer, TMB high, where we may see, where there's agnostic tumor approvals. But I think in general, ovarian cancer in the frontline, immunotherapy really doesn't play a role to this day.
All right, let's talk about platinum-resistant ovarian cancer. We're going to get into, I think, one of the most interesting studies in the ESMO meeting, looking at Pembro now but now in the platinum-resistant, and coming up with a little bit of a different answer, but I want to see what you think about it. Let's start out with the case here. You have this 61-year-old woman. What happened with her?
Yeah, so to briefly summarize, this 61-year-old who presented with actually a very large disease burden as well. She was noted to have an enlarged inguinal node, and biopsy was confirmed for metastatic high-grade serous carcinoma, making her a stage 4B. You can see her tumor testing, which was done, HRD positive, folate receptor 1 positive, I think it was 90%, and then tumor mutational burden, 9 mutations per megabasis. She was actually started on neoadjuvant chemotherapy, received 3 cycles, was able to undergo debulking surgery with complete cytoreduction. But you can see she had an excellent chemo response score of 3, and then she completed her therapy, and she did receive bevacizumab in that post surgery setting. She was then started on olaparib and bevacizumab maintenance. She did pretty well in regards to tolerability, but unfortunately her disease progressed, and so she discontinued therapy. She was found to have a mammary node that was pretty large, which was biopsied and confirmed. And then she was, and at this time we tested her HER2 status, and she was noted to be HER2 2+. She was started on carboplatin liposomal doxorubicin as she had a platinum-free interval of greater than 6 months, and she received 4 cycles. She did have some toxicity here. She received some radiation to that she received to that mammary node because she was kind of having some symptoms from it. And then her PET-CT scan showed that she was having good response until she started developing an enlarged inguinal node. So most of her disease was nodal, interestingly enough. Because of her folate receptor status, she was actually started on mirvetuximab. She tolerated this well, received 7 cycles, but then was found to have disease progression. We actually then opted to go back as her 4th line of therapy to a platinum base with cisplatin, gemcitabine, and bevacizumab. She did experience some hematologic toxicities and received 4 cycles of this therapy. Unfortunately, once again, and not unexpectedly with kind of recurrent ovarian cancer, she had disease progression. And because of her HER2 status, and the NCCN guidelines, which have HER2 2+, 3+, we were able to get trastuzumab deruxtecan for her. This was now her 5th line of therapy. She received 5 cycles of this, and then unfortunately had disease progression. This time she started having more peritoneal disease progression, so kind of still her lymph nodes, but also peritoneal disease. And after our discussion, we started her on pembrolizumab, bevacizumab, and cyclophosphamide. This is now her 6th line of therapy, which she started in October of this past year. And she's actually still on this regimen. I just saw her earlier this week, and she's still on this regimen. Tolerating well. She does have some GI symptoms, her scan showed what we think is pseudoprogression, and we're going to show you her CA. I think we're going to start showing you her CA-125s, which were increasing, but have actually now plateaued and started to downtrend. So we're hoping that she's showing a response. This is just her historical CA-125s from early 2025, excuse me. And then you can see that it's kind of been all over the place. And then she really jumped up. So we started her on the 6th-line regimen of pembrolizumab, cyclophosphamide, and bevacizumab in October. And you can see she did increase, but she's now starting to plateau and actually just had a recent decrease at her most recent visit.
So, really interesting case. I want to ask you a few things about the case. First of all, it was interesting that you did SBRT on an oligomet. It was a internal mammary node. Can you talk a little bit about how often you see oligometastatic disease in the ovary and how you approach it locally?
Yeah, and so it's a great question. I wish I saw it more often than I do, but I do every once in a while we do catch a patient who has oligometastatic disease. And depending on the location, there is data looking at SBRT in these patients with oligometastatic disease, and it's kind of pan tumor. But you can see some long-term responses for patients. So I do like it as an option, low toxicity, good response rates, if it's an area that's amenable to it. So it is something I'll consider in patients and have a nice talk with them. The nice thing is also it doesn't necessarily delay systemic therapy. So if a patient's symptomatic, you can still use it without really delaying or deferring their systemic therapy while they're getting that treatment.
So we're going to talk about folate receptor alpha as a target of some other agents. Obviously, we have mirvetuximab, which she received. Just kind of curious how she tolerated it. Do you have any toxicity and any ophthalmic issues?
She did. So this patient's a singer, and she's did experience some shortness of breath. So we were worried about pneumonitis type picture. Her scans were always favorable, and she was able to do it. But she did actually complain. I shouldn't say complain, but she did endure shortness of breath, which did affect her ability to sing.
So yeah, I was talking about the mirvetuximab though.
Yeah, that's a pneumonitis. That's where she actually had we thought it was like
I thought you were talking about the
right?
TDXD.
No, it's actually from the mirvetuximab. Her
really?
eye is ocular. Yeah, it is associated with it. They actually had a black box warning that came out too about it. She technically never had ILD or pneumonitis, but she did have symptoms of shortness of breath. Her ocular exams were always unremarkable. She did actually really well from an eye examination standpoint, tolerability.
Also, it was interesting that you gave her an IO. I see she had a TMB of 9. I'm guessing that's why you did that. We had a wild case we just presented at the ASCO GI meeting of a patient with TMB of 14, not MS stable, who had incredible response for a couple years, which I've never seen before. What's your experience using IOs in people just with TMB? And do you have it? Was that on a liquid biopsy? Do you have any concerns about looking at TMB with liquid biopsies?
Yeah, a great question. And I can't say my experience with liquid biopsies in TMB is very robust. So this was actually based on her initial tumor testing. So it was actually based on her tissue. The regimen we used, cyclophosphamide, pembrolizumab, and bevacizumab, was based on phase 2 data. And honestly, as you can see, this was her 6th line of therapy. We start, kind of thinking about strategizing quality of life and a regimen. So we wanted to give her something that wasn't going to be too toxic. She had already had dose delays, or we had to hold therapy because of prior hematologic toxicity. So I was trying to find something that would work for her. TMB of 9, I know the cutoff's 10, but it was kind of compelling, and because of the NCCN guideline listing, we were able to get it approved for her.
So what I'm really interested to know would be if this lady, I don't think you told me you didn't even have a PD-1, but I think maybe some people are going to start getting PD-1 because of a big presidential paper that was presented, this keynote B96 study. Finally, we see IO in ovarian cancer. It seems like a positive study, but I'm curious what your take was. Can you talk a little bit about the design and the outcomes that we're seeing here and what you think about in terms of clinical applicability?
Yeah, so this study was really looking at weekly paclitaxel with or without bevacizumab. That was physician choice. And then the real control of the study was placebo versus pembrolizumab. So really looking at whether IO plays a role in the platinum-resistant setting. We to date have not seen strong signals in this setting. So this was actually, a lot of buzz. We had a press release prior to this presentation that it had met its endpoints. And you can see here that the primary endpoints were PFS and secondary endpoint of OS. Here you can see they did look at PDL1 score CPS. And I just want to highlight that we actually have never really looked at this in ovarian cancer. So whether it's PDL1 or whether it's another immunotherapy marker, we just don't really know what maybe the right target is for patients with ovarian cancer. They did look at it less than 1 to 10, and then greater than 10. So you can see the kind of a pretty equal distribution amongst those. And here you can see the primary endpoint of PFS. They looked at the CPS greater than 1 population, once again, kind of an arbitrary assignment. And they did show that the hazard ratio was 0.72, so about a 30% risk in progression of disease. And then here's that subgroup analysis. And I'm sorry, I think maybe I jumped ahead. You can see that a lot of patients did receive bevacizumab. So the pembrolizumab did really add something to this patient population. I do also want to just highlight that this was a patient population that only had 1 to 2 prior lines of treatment. So it was a group that maybe wasn't as treatment heavy as some of the ones that we see in our platinum resistant setting. And then here you can see at interim analysis too, it continues to show. And then the overall survival here, which was also significant with a hazard ratio of 0.76. So clearly they are showing some signals of immunotherapy benefit in this patient population. I think it's still I think some of us are still struggling to kind of understand who those right patients are for this, but there is a signal.
So specifically, and I guess adverse events is pretty much, I think, what you would expect, and we've seen in general with chemo plus IO in terms of the type of adverse events and the immune-related, particularly hypothyroidism.
That's exactly right. And I think that most of us are comfortable using this regimen, these combination of drugs. So I think it's, no new safety signals that were concerning.
So can we drill down a little bit on how you and maybe your colleagues that you've been talking to think about this? The discussant there who discussed the paper is very positive. When I watch that, I'm like, oh, it sounds like this is going to be practice changing. But then when I talked to you a few minutes ago, I wasn't so sure. So what are you thinking?
Well, okay, I'm going to qualify this as my own opinion. So I don't want to speak for anybody else, but I do know some people who agree with me, and I know some people who are very excited about this. I think it's a familiar regimen. Using addition of pembrolizumab, I think will be easy to incorporate. My enthusiasm for the study is probably neutral. I think there's definitely a role for it. I think that, I had mentioned that I use that pembrolizumab, cyclophosphamide, and bevacizumab regimen. And the reason why I like that is going to be another study that we're going to talk about that also uses a weekly taxane. And I think kind of understanding, these patients are typically going to see multiple lines of therapy, as you saw my patient who was on our 6th line of therapy. And how do you sequence therapy so you don't lose kind of, any edge of survival, but you may be able to keep other lines of therapy open or viable. So I think that this is a regimen that, probably I'll use, but it probably won't be my go-to in the platinum-resistant population. I'd love to understand which patients are really more, susceptible to the immunotherapy benefit or checkpoint inhibitor incorporation. I know the PDL1 score. I would love to see a little bit more, translational science or understanding of why, that may be significant, or maybe there's a better marker for these patients. I struggle with this a little bit.
So I love our chat room. Priya, Dr. Rudolph just put in there, how do you choose between relocalcitrin and Pembro? And we'll get into that in a second. She's totally on target, but also, and even more, this discussion by Professor Ray Kokard was interesting because I kind of all of a sudden realized that not only do we have a biomarker-driven approach to maintenance therapy up front, but we're really quick. It seems like we're there in terms of biomarker-driven approach to platinum-resistant disease. And she points out, of course, as Dr. Rudolph points out, the issue of recalcitrant. You have MERV in terms of patients who are folate receptor positive. Maybe we have Pembro for people who are PD-1 positive, and we have TDXD for HER2. So you really are seeing the evolution of a sort of a biomarker-driven approach to at least platinum-resistant disease. And then we just saw, I think it was yesterday, this press release came out.
It was this morning.
Oh, was it today? Yeah. Yeah, I lose track of days here. But anyhow, our team got all over it. And so we did see data from this is the older paper from the study, but we also saw data, more interim data, I think, from the Rosella study. This analysis that the press release talked about, hopefully presented soon. I don't know, maybe at the SGO meeting, who knows? But can you talk a little bit about, again, this question of particularly if they're HER2 negative and they're FR alpha negative, and they're PD-1 greater than 1, and does it matter if they're 10 or 20, how you're going to think through these various choices?
Well, to give the folks a little bit of background, the Rosella trial actually looked at relacorilant, which is a glucocorticoid receptor target, and with a combination of nab-paclitaxel, and this was given weekly. Relacorilant is an oral agent. It's kind of given right around the time of the weekly infusion, so it's a shorter course, not a daily course. And the really interesting thing is that the goal of this kind of combination is to overcome chemotherapy resistance. So it makes the cells more susceptible to the chemotherapy. And I think this study really does show like kind of the proof of biology or rationale here, where you can see a PFS benefit, but you can also see, and today they reported that overall survival benefit. So you could really see that this drug kind of does what it says it's going to do. I think the challenge is going to be that weekly taxane, because it's going to be hard for patients to get weekly paclitaxel and then weekly nab-paclitaxel or vice versa. And so you may have to decide which regimen is better for patients. Both relacorilant and the Keynote, Rosella and the Keynote B96, maybe patient all comers. Maybe you do strategize by CPS or PDL1 expression. But I think the relacorilant is kind of for all patients. So I think it's an option, and you just have to decide what's going to be better for your patients.
So starting to think about where things might be heading in the near future, I'm curious about your thoughts about this presentation. Very interesting ADC with a kind of a new target that we haven't heard too much about. Tell us about the Rejoice, and I love the title, Rejoice Ovarian Study. That's a good one. Tell us about RDXD.
Yeah, so RDXD is targeting Cadherin-6 or CDH6. And so this was a study in patients who had received 1 to 3 prior treatments with bevacizumab. So kind of your classic platinum-resistant ovarian cancers. And this was kind of a dose optimization trial. And so they looked at several different dosages. And what was really remarkable about this is they looked at CDH6 expression, but actually they saw responses in all comers. And this is a really beautiful waterfall plot that you can see here, where you saw anti-tumor activity across all dosages, and they don't show it here, but you actually saw responses across all expression levels of CDH6 as well. So I think this is something to keep your eye on. I do want to highlight that Rejoice that RDXD is a topoisomerase 1 inhibitor. And so this is I think this is one that's, again, a question of sequencing, is how do we sequence these patients with, similar payloads, and does expression level of CDH6 matter? And here you can see, responses across the expression levels.
Yeah, the discussant for this paper brought up the issue of sequencing, and we hear this all throughout oncology in terms of sequencing of ADCs, in terms of, do you look at the payload, do you look at the target? Mm-hmm. He seemed to be I think he was more oriented around the payload, but how are you currently thinking? Some people say, like breast, obviously, you see this a lot because they have so many ADCs. You hear people saying, we don't want to do ADC after ADC. We want to put something in the middle. How do you think about sequencing?
Yeah, so right now we don't really have that many approvals, and the ones that we do have, fortunately, don't overlap. But I think with mirvetuximab, which is a DM4 payload or a tubulin target, you could probably re-challenge these patients with another ADC that's targeting something different. In our case, we often think of chemotherapy being the resistant factor. So I think the payload makes more sense to me, but I think we have to prove that. And if a patient does have the ability to tolerate something, maybe the target is, maybe the drugs weren't getting effectively to those areas. So maybe the target really is important. So I think we have a lot more to learn, but I do think this is something that's very exciting and compelling in earlier studies. And here you're showing the side effect profile, the emergent treatment-related adverse events. And you can see pretty well tolerated, mostly grade 1, grade 2, but there are some GI toxicities, which I always like to highlight. Ovarian cancer patients often have baseline GI toxicities. So it's important to kind of distinguish, how to manage those from treatment and versus disease, but also some hematologic toxicities.
And of course, we'll learn more as we see more data coming up. It looks like they didn't see a lot. Well, they saw one grade 3 or greater ILD event, but mm-hmm. with the deruxtecan payload. Of course, people are going to want to look at that and at
Right.
least initially screen very carefully. You were talking about mirvetuximab causing ILD. Incidentally, before we get to this next topic, we were talking about sequencing. We'll get into this later, but I'm curious because we had a couple of cases that we presented at a meeting recently of people who are both HER2 positive and folate receptor alpha positive. How do you decide which comes first? And we use one after the other.
Yeah, so I would definitely use one after the other in this case. So I'm a little bit of a purist. I would probably favor the mirvetuximab. In this case, we have phase 3 data with both progression-free and overall survival benefit. And I think that there's some data that's emerging that's showing that maybe using the tubulin target versus the topoisomerase 1 target, in that sequence may be more beneficial or favorable, although that's maybe a little bit more hypothetical. So I would favor the targeting the alpha folate receptor payload with the mirvetuximab followed by like the trastuzumab deruxtecan, which is based on phase 2 data. So it's an accelerated approval. We haven't seen, we haven't seen that in the phase 3 data yet. Phase 3 results yet, but hopefully that'll come. The results were so provocative, though, that it makes sense that it was available to patients sooner.
So as you mentioned, that's a pretty good looking waterfall plot there for RDXD. What do you see in the future? We were talking about the algorithm for platinum-resistant disease. Any projections about where RDXD is going to fit in?
Yeah, I think it depends on what we end up finding out with the biomarker expression. Does that matter or does it not matter? And so I think if it matters, then I think you have those patients who are biomarker selected who would get this drug. If it doesn't matter, I think that becomes a little bit more challenging because I think we're going to talk about alpha folate receptors, the next kind of generation of alpha folate receptor targets, which also will kind of crowd this space. And, patients can only get so many therapies before their toxicities start to prohibit them. So it's going to be challenging, but I think it's an exciting drug and it may be right for certain patients.
So again, speaking of FR alpha, we saw, and there's several ADCs with this target in development, including this one that I guess doesn't have a name, AZD 6335. There was data, this is, I guess, a phase 1 or B or
first in human.
Earlier, right. Can you talk a little bit about this agent and what they reported here?
Yeah, and so this was really dose finding, just kind of understanding it. And I think that this is just, highlighting what you were just saying is that this is a really ripe target in ovarian cancer. We don't know a lot about this agent yet. I personally have not used this agent. We weren't on this study, but I think you can see here that they are showing some provocative data from their phase 1, phase 2 study, but I think we need a lot more to learn. And then once again, who are going to be the right patients, and then which ADC alpha folate target is going to be the one that, maybe is first to the game here.
How often, it kind of reminds you a little bit about HER2 low. How often do you see FR low? And if we find that some of these new agents like this one work with FR low, how many people do you think that's going to affect? Is that common to see that?
Yeah, FR low is actually the more common finding. So I think if we find an alpha folate target that works across the board, it's going to be pretty successful.
All right, let's move on to endometrial cancer, particularly metastatic endometrial cancer. And we're going to start out with, it wasn't that long ago that the approach was somewhat different than what happened in this patient. This is 2026 first-line therapy of metastatic endometrial cancer. What happened with the 68-year-old lady?
Yeah, so she was actually diagnosed with early stage disease. So she underwent surgery after her initial biopsy and had stage 1B, grade 2 endometrial cancer. She was noted to have a DMMR tumor. And so at that time, this is 2021. So she actually had the option of enrolling on GY020, which is looking at radiation with or without pembrolizumab. It was an open label trial. So we know she got randomized to the control arm and she did well. She did have this like a left periodic lymph node that we were kind of keeping our eye on, and she did pretty well on it for a fair amount of time. However, as you can see, she started having some enlargement of it in 2024. So we biopsied it at that time, and it did confirm carcinoma consistent with her prior history. And so we then started her on carboplatin, paclitaxel, and dostarlimab. She received 5 cycles, but started having some side effects. This patient's really amazing. She's a marathon runner. She's a globe traveler. So she opted to drop her last cycle of chemotherapy and start her dostarlimab maintenance at that time. Excellent response to therapy. Her PET CT scan, kind of right at the end of chemotherapy, showed that she had essentially lymph node resolved back to a normal size and no FDG uptake. And she continues to show a robust response. She's doing well, and I just saw her this week, and just got back from Hawaii, so she's still living her best life.
So can you talk about the current approach to metastatic endometrial cancer right now in the first and second line setting? We'll take a look at some data. I don't know if it's practice changing, but just some more updated data from some of the key trials, but how you approach that, and also the issue of patients like this who are MSI high. Do you always give them chemo plus an IO, or do you ever try an older patient, you offer the possibility of just IO alone?
It's a great question, and I think we're still learning the right answer to that. So I think if a patient has mismatched DMMR status, then yes, they are definitely candidates for checkpoint inhibitors unless there's a reason they cannot get it. It is FDA approved for patients with advanced or unresected, like residual stage 3, stage 4 disease. And so I think it's a good option for those patients. I think we're being a little bit smarter about it. So I don't think it's maybe one size fits all. I think there's things that are coming on the market like P53 wild type with selinexor. You have P53 mutated patients who, maybe IO, maybe bevacizumab, maybe, these are not on label, but just some thoughts that we're thinking. And then you also have the HER2 expression, which is common in endometrial cancer. And there are studies looking at trastuzumab and pertuzumab. And then, of course, in the recurrent setting, looking at TDXD. So I think it's an evolving landscape, and so I think we're trying to learn more about which patients benefit the most from which drugs up front.
And choice of IO, dostarlimab versus pembro?
I think both are comparable. So I think it's, sometimes what's on your formulary, what, they're given at the same duration intervals. So I think it really depends. I use both, and I haven't really seen a difference in toxicity or profile overall.
So any situations, sort of excluding people with prior autoimmune disease, et cetera, right now where you don't use an IO first line? When these trials came out, I wasn't really clear exactly where it was going to head, whether some people might want to wait. We see lenvatinib pembro as second line therapy. How's this sort of fleshed out, and particularly in the investigator community? Does everybody pretty much get an IO up front?
I think you're seeing a kind of a little bit of variation. There are some people who do IO up front for everybody. I'm a little bit more selective, I would say. I think in the patients who are P53 wild type, we do have the selinexor trial open. So I do like that option for patients, which is targeting the XPO1 protein. So trying to kind of reactivate the P53 gene. I think that makes a lot of sense for these patients, but it's still a very nuanced world.
Yeah, that selinexor is really fascinating. I can't wait to see what that study shows. So I mentioned we just got back from the GI ASCO meeting. We did 3 CME programs. One of them, we were talking a lot about IOs and the adjuvant and neoadjuvant situation. Last year at the big ASCO meeting, we saw the plenary presentation. Now looking at chemo plus IO and the adjuvant situation, we'd already seen these wild data from starting out with memorial and rectal cancer and MSI high disease. We talked a lot about that, using it neoadjuvantly, avoiding surgery. And I was surprised and happy to see this poster here of a trial in progress. Looks like they're kind of looking at the same strategy with dostarlimab and MSI high localized disease. Any thoughts?
I think this trial in progress is actually really interesting. I was saying earlier that endometrial cancer is usually curable by surgery, but for these patients with more locally advanced disease, this may be a good option. I think the other population of interest is maybe those who desire fertility preservation and have mismatch repair deficient tumors.
Yeah, you brought that up when we were talking before. It kind of reminds me a little when we were talking about the idea of MSI high colon cancer and the fact that you can just take it out. Do you really need to do the IO? And you could say the same thing about endometrial. But as you point out, the fertility issue, I think that's really interesting as a possible, maybe potentially offering it to these patients.
And in this study,
go ahead.
Oh, sorry to interrupt you. In this study, I think it might be interesting because maybe we can avoid radiation in these patients. Maybe we can avoid, other therapies because these are patients with more locally advanced disease. So I think it still plays a really provocative role.
So we continue to see data coming out of the 2 main studies, and here we saw at the ESMO meeting more data looking at survival outcomes in the RUBY trial. Anything you want to say about that, and in general, how you view the 2 big studies here, the RUBY study and the NRG study?
Yeah, this is kind of just piecing out some of the information a little bit more. I think the study is interesting because it actually looks at the adjuvant therapy given after progression. And so here you can see that patients who receive chemotherapy as their first line after they progress, maybe the patients who receive the dostarlimab actually had a more like a prolonged PFS and OS, or excuse me, OS here. But patients who received lenvatinib and pembrolizumab, so now patients who were receiving immunotherapy here, checkpoint inhibitor, who didn't receive it up front, you can see that maybe those responses are kind of starting to catch up. And I don't really like that word, but I don't know how else to say it. So, I think it still shows a role for immunotherapy early on in the treatment for these patients with endometrial cancer, whether you choose to use it up front or whether you choose to use it as a second line therapy. I think still we need to tease those out, and maybe that may be based on patient factors, things, strategies such as that.
So I want to ask you also about the 10 study looking at atezolizumab, the PD-L1 inhibitor with chemo, which didn't have quite the same benefit that we saw with dostarlimab and pembro. And it was interesting, the discussant there at ESMO brought up this issue of PD-1 versus PD-L1, which you don't hear that talked about too much, and he was, I think, saying that in the hot tumors, maybe it doesn't matter, but maybe in the cold tumors, it does. Any thoughts about that?
No, I think I echo those concerns. I mean, the dMMR population still had a really pronounced response. It's that MMR proficient population that really didn't. This maybe, not to go back to the DUO-E study, which is a little bit messier, but maybe the combination of something else along with immunotherapy, whether it's lenvatinib and pembrolizumab or durvalumab and olaparib, something else to maybe kind of up that immunogenicity of the tumors. But I agree. I think that a 10 trial doesn't really inform much in the United States. Atezolizumab's not really used here for this indication.
Any thoughts about the difference in mechanism, in terms of hitting the ligand versus the receptor, in terms of PD-1 versus PD-L1?
It makes PD-1 seem more robust in responses. That's what we've kind of seen in GYN cancers, including ovarian cancers. We saw avelumab not have responses. So I think we kind of have that feeling, whether it's true or not, I don't know. But, I personally tend to favor the PD-1s because of that.
Any comments on this follow-up data from the DUO-E study? Actually looking at IO plus PARP, but this was a presentation looking at TMB and the patients who got IO durvalumab.
I think we know that tumor mutational burden, tumors that are high in tumor mutational burdens have a favorable response to immunotherapy, and this study just kind of reinforces that. So I don't think there's any big takeaways. There are some overlap between TMB and mismatch repair status, but those are the patients who are going to be most responsive to immunotherapy. And that's what the study really shows.
We saw a couple papers. I've kind of been surprised and disappointed that lenvatinib pembro hasn't gone farther. It's so encouraging in the second line setting. We saw some follow-up data at ESMO looking at lenvatinib pembro in 2 studies. This is a 5-year outcome from the Keynote study. Any comments?
Yeah, I think they just show long-term data now. So, it's been around long enough that we can see that, it continues to have support the role for lenvatinib and pembrolizumab. This study looked at the frontline patients who received neoadjuvant therapy, so kind of in that second-line setting. And I think we do see a really significant impact with lenvatinib and pembrolizumab. Of course, these are all patients who never received frontline immunotherapy, so you're maybe excluding patients from this if you're using it up front, but that once again, that's a little bit more nuanced. I agree. I think we're going to see some more data on dMMR patients, just like you said, with immunotherapy. But I think right now, lenvatinib and pembrolizumab is kind of positioned in that second line setting for patients who are IO naive.
Any new clinical pearls about using lenvatinib pembro, particularly your approach to dosing, which has been heavily discussed over the years? How do you approach it?
Yeah, I think, we're learning, a lot more. I think there are people who may use different dose strategies. Some people will start at 18, 14, just depending on ease of dose reduction. A fair number of patients will require dose reduction. You can also look at renal function because, those patients may have tolerability issues. So being strategic about starting patients at lower dosages who are at high risk. And counseling patients on blood pressure, monitoring is really important. These are real side effects, but I think with appropriate counseling, monitoring, and management, you can keep patients on effective therapy for long periods of time.
So I was kind of surprised to see this trial in progress in endometrial cancer. We at the last ASCO meeting, we saw the presentation in breast cancer, the combination of IO pembrolizumab with sacituzumab that beat out chemo plus pembro, and so that now is really, I guess, first-line therapy for triple-negative breast cancer. But here we are again, another TROP2 ADC not approved in the U.S. right now, SAC-TMT, similar target, and adding in pembro. Any thoughts about where this is going to head?
Well, I think this kind of capitalizes on that earlier point is the mismatch repair proficient may have a response to immunotherapy, but it's really not that, attractive. We need to do better. And so I think figuring out others, we know TROP2 expression is really high in endometrial cancers or most gynecologic cancers. So I think it makes it a ripe target. And we just had two phase 3 trials looking at TROP2 targets in the recurrent endometrial cancer setting. And so hopefully those will, add a new tool to our treatment of recurrent disease, but there may be a role for it even earlier.
All right, let's talk about HER2 positive gynecologic cancers and particularly the evolution of TDXD. It's been so interesting for me to see, after having, talked to so many people in general oncology using TDXD and breast cancer, how that came into being. And now when we have gynecologic oncologists presenting cases, I see that same smile on their face as they present the patient they never imagined was going to respond who does. Here's an 84-year-old lady. What happened with her?
Oh, she's a delicate one, but she is tough. So she had a stage 2C high-grade serous endometrial cancer. She was pMMR, HER2 2+, and P53 mutated. She received the six cycles of carboplatin paclitaxel, did pretty well for a short period of time, but you can see about 5 months later started having recurrent disease. She actually was not treated by me initially, and so she came to me at this time. She was very adamant about not doing lenvatinib and pembrolizumab, which we had talked to her about pretty extensively, and had opted to start trastuzumab and deruxtecan as her second-line therapy. She's actually had a good response in her peritoneal and omental disease. She still has disease, but she's actually showing a really nice response. We're assessing her every other cycle for ILD with CT scans of the chest, but she's continuing on therapy, and we plan reassessment after cycle 6.
I'm curious how she tolerated TDXD. As time went on, we started hearing more and more about acute GI toxicity. I always like to ask outside of breast cancer what people's experience are. The breast people are very aggressive in terms of anti-emetic strategy. How did this lady do, and what have you seen in general in terms of acute GI toxicity?
Yeah, definitely seeing a fair amount of GI toxicity with this drug or this agent. And so I think I've kind of adopted a similar strategy of kind of being aggressive with antiemetics up front. This patient did actually require a dose reduction of her therapy. She's starting to have some hematologic toxicity, but nothing that's prohibitive. So she's doing pretty well on it. And, like I said, she's 84. So this is actually remarkable that she's able to kind of continue on this therapy.
Yeah, last year at San Antonio, we had 2 cases of 90-year-old patients that got TDXD. Both of them responded and tolerated well, but everybody in the audience was like taking a deep breath when the doc explained what they would do. Colton, again, in the chat room, brings up the issue of HER2 2+ that's not amplified. This patient was HER2 2+. A lot of times people aren't getting amplification, although you can see that on NGS. What do we know about TDXD based on, and we're going to talk about some of the follow-up data that was presented at ESMO, but how are you thinking through HER2 2+ versus 3+?
This is based on the pan-tumor02 data where they looked at just the IHC expression. So they didn't really look at amplification, and the ADC may be a little bit more sensitive. If we're using trastuzumab, itself as a monoclonal antibody, then I think amplification matters. So I think in this case, it's in the NCCN guidelines for HER2 2+, and I think I kind of capitalize on that. But at the same time, I think maybe there may be differences in responses, but at this time, I think it's a reasonable option. The data from the pan-tumor trial, Destiny pan-tumor, did show really provocative responses, most provocative in HER2 3+, but we did see some impressive responses in HER2 2+, and those patients tended to be heavily pretreated. So I think it's a good option for patients.
So we'll talk a little bit about where things might be heading in terms of HER2 disease and particularly TDXD. Of course, in breast cancer, not only we have first-line metastatic disease, again, I think it was the last ASCO, but then at the ESMO meeting, we had neoadjuvant therapy with a TDXD. So and adjuvant as well. So we'll see where that, or post neoadjuvant as well. But let's talk a little bit about some of those things that came out. We saw some more. You were mentioning the pan-tumor O2, and we saw some more follow-up data. I think everybody's seen this very colorful slide where you see, three gynecologic cancers in a row. Any comments on this study? And I guess the follow-up data really just similar to what we've seen before.
It's small cohorts, so we have to take that into consideration. But you can see the IHC2 plus that I was just referring to, 47% response rate in, patients who've had prior treatment. So it's pretty compelling, but I do agree that, it's still very early. We should get more data. But the overall survival data here is really just impressive. So you can see 33 months with IHC3 plus for endometrial cancer, 35 months for cervical cancer. These are numbers we've never really mentioned, and sometimes not even in the front line. So these are really, really provocative data.
Was your patient having tumor-related symptoms when she started the TDXD, and did they change or improve?
She was having a lot of GI symptoms. So and this is one thing I was saying, like GYN cancers often affect the GI. So sometimes determining what's treatment related and what's disease related may be kind of nuanced or maybe compounded in the beginning even. But because she had ascites, so she was having a lot of abdominal symptoms.
So we also saw, this is more data kind of drilling down more in terms of biomarker analysis in terms of HER2. Again, we have the IHC3 plus versus 2 plus. What about the information that you get from an NGS? Because they report HER2 overexpression as well. Is that something that you'll act on, or do you need an IHC?
No, because when we send it out to a lot of these commercial parties, third parties who are doing tumor testing, they'll actually just show the IHC expression. So you can order IHC in addition to the NGS. So you can get a lot of information up front.
Interestingly, very unusually, it looks like we have a patient, I don't know if she's a physician as well, but who was in the chat room, who says she's been on TDXD for 16 months and doing well. So
awesome.
There are lots of people walking around right now are feeling a lot better because of that. Let's talk about where things might be heading. Mm-hmm. Rilvegostomig is being looked at in a number of different tumor types, including endometrial cancer, but also, of course, pembrolizumab and IO. This is MMR proficient recurrent ovarian cancer. Any thoughts about this trial in progress?
No, I think this is the space that's really popular. I think that mismatch repair proficient is like our new HRD test negative or HRP patient population. We really need better therapies for those patients. So I think that these are really exciting concepts, and I think we have a lot more to learn.
I always love trial and progress posters. They're so cool, and you really start seeing what's going to happen and why people are doing it. How about this idea of using TDXD plus Bev? Any thoughts? This is again HER2 overexpressing ovarian cancer.
Yeah, like I said, I think these are tough patients. These are exclude patients who are eligible for PARP inhibitors, of course. So I think it's trying to capitalize on those patients who are high risk for recurrent disease where we don't have great targets for them. I'm not one to just throw everything, at patients. So I like to always see a little disease biology, and I like that they're picking HER2 overexpressing cancers here where they're really targeting that biology.
So we're going to finish out with cervical cancer, but somebody in the chat room asked about HER2 positive cervical cancer. Do you see that, and do they respond?
It's pretty rare. My partner actually has one right now, and she is HER2 3 plus. She is, I think, a gastric or adenocarcinoma, and she's having a wonderful response. She progressed on immunotherapy, the Keynote 826, and having a wonderful response. I think it's rare, but it's worth looking for.
All right, we'll finish out with cervical cancer and hear about your 75-year-old patient.
Yeah, my elderly population here, but this patient's also very spry. So she was found to have cervical cancer. You can see a cervical mass that lit up on PET CT scan. She also had some lymph nodes. We biopsied it. She had a papillary squamous cell carcinoma with a CPS greater than 1, and she was diagnosed with a stage 3C1R, which means positive lymph nodes on imaging. This was also confirmed on MRI. So she started with external beam radiation and receiving cisplatin pembrolizumab during her external beam radiation, followed by cervical brachytherapy, and she's now currently on pembrolizumab maintenance. She's had complete resolution of her disease. You can see that her scans have been negative thus far, and she's planning to receive pembrolizumab maintenance for a total of 15 cycles. So she's kind of getting closer to her endpoint.
Anything you want to say about this clinical scenario and your experience using chemo and pembrolizumab as well as follow-up brachytherapy?
I will say that almost all the patients who receive this regimen tolerate it really well, or kind of comparable to what we see with chemo radiation alone. The pembrolizumab really doesn't add much toxicity. Fatigue is probably the most common thing, but patients are doing remarkably well on this. And with based on A18, we saw survival data, so survival benefit. So I think it's a really important incorporation for our patients.
So there was a pretty cool paper presented, and this is in first-line therapy of metastatic cervical cancer. Let me just start by asking, right now, what's the standard of care and how do you approach first-line therapy? And what about patients who've had prior IO, incidentally, and chemo?
Yeah, so that's a great question. I think time might matter. So maybe the interval, if you had chemo radiation with IO, maybe there's a long interval, then re-challenging with IO may make sense. If they progress on it, maybe less so. And so the standard of care for frontline is really chemotherapy with a platinum taxane-based regimen, bevacizumab, and then pembrolizumab if they have a high CPS or CPS greater than 1 is what's approved in the United States. If they don't, then it's just bevacizumab with the chemotherapy regimen. And so this study kind of recapitulates that, looking at IO plus a TKI and versus chemotherapy. So it's a little bit more provocative of can we drop chemotherapy in some of these patients.
Any comments about what they saw and whether you think this is clinically applicable?
Well, I think it's clinically applicable to them. I think we need to see it in a more global representative population where there may be some heterogeneity in tumor biology and patient populations.
Any thoughts, any future strategies in cervical? I think they're looking at tisotumab plus IO. We were talking about ADC plus IO, how they're doing that in breast cancer. What's the next step in metastatic cervical cancer?
Well, we have a trial looking at TROP2, sacituzumab tirumotecan, which we're hoping will pan out, and it's comparing it to tisotumab vedotin. So we're hoping to, maybe have a new option for patients with recurrent cervical cancer.
What's your experience with tisotumab vedotin? And also curious about tolerability issues that you see.
Yeah, the biggest issue with tisotumab vedotin are the eye toxicities. It does require a lot of eye care and eye drops, eye visits, which can be restrictive for patients who maybe already have access barriers to healthcare. And then the other issue is neuropathy. And neuropathy is a real issue for these patients because they've also received taxane or most likely received taxane beforehand. So those toxicities are real, and just kind of being thoughtful about how to manage those patients, dose reductions, dose interruptions can be critical.
So, Ritu, thank you so much for working with us today. It was so informative. Thanks so much for attending. Have a great night. Thanks so much,
Bye,
Ritu.
everyone. Thank you.